duration of dual antiplatelet therapy in patients with acute coronary syndrome. Go ahead, please. Thank you. Is the mic working?
It's not working. Can someone help him? His mic is not working.
Thank you, Chairman. Good afternoon, everyone. I'm Ju Yong-han from Samsung Medical Center, Seoul, Korea. Major guidelines recommend dual antiplatelet therapy for at least 12 months in patients with ACS after DES implantation. However, the optimal duration of DAPT remains controversial. The PCI Cure study has been cited as the most important and direct evidence supporting prolonged DAPT in patients with ACS. However, this study compared DAPT versus aspirin monotherapy rather than duration of DAPT. Moreover, this study was done nearly 20 years ago. Therefore, direct application of its results to contemporary clinical practice is very difficult. Several years ago, our group conducted the excellent trial to compare 6 months DAPT versus 12 months DAPT. In this study, 6 months DAPT was non-inferior to 12 months DAPT. And there was no significant interaction between clinical presentation and treatment effect of two DAPT regimens. However, in this study, a relatively low risk of ACS patients were enrolled and the STEMI patients were excluded. A recent meta-analysis also reported that 6 months DAPT was not associated with increased risk of myocardial infarction or stented thrombosis. However, again, enrolled ACS patients had a relatively low risk and patients with MI less than 10%. Therefore, recently, 3 RCTs have been conducted: SMART Date, DAPT STEMI, and reduced trial. The sample size was 2,700, 1,100, and 1,500 patients respectively. DAPT STEMI trial enrolled STEMI patients exclusively, but the other 2 trials enrolled a broad spectrum of ACS patients. DAPT STEMI trial was a prospective, randomized, non-inferiority trial. 1,100 STEMI patients underwent primary PCI with the second-generation Zotero-Lumiciluting stents and were randomly assigned either to 6 months DAPT or 12 months DAPT in one-to-one fashion. The primary endpoint was a composite of death, MI, revascularization, stroke, and major bleeding. At 2 years, the rate of primary endpoint was 4.8% in 6 months DAPT group and 6.6% in 12 months DAPT group. There was no significant difference between the 2 groups, and non-inferiority of 6 months DAPT was met. The second trial was reduced study. In this study, 1,500 ACS patients were randomly assigned either to 3 months DAPT or 12 months DAPT. At 1 year, the rate of primary endpoint was 8.2% in 3 months DAPT and 8.4% in 12 months DAPT group. There was no significant difference between the 2 groups, and the non-inferiority of 3 months DAPT was met. However, there was a strong trend of increased risk of all-cause mortality, cardiac mortality, and stent thrombosis in 3 months DAPT group compared with the 12 months DAPT group. Our group conducted a smart data trial to investigate whether a 6-month DAPT would be non-inferior to the conventional 12-month or longer DAPT after implantation of DES in ACS patients. This was a prospective, multi-center, randomized, and open-label trial. 2,700 patients with ACS underwent PCI using current generation DES. The patients were randomly assigned either to 6-month DAPT group or 12 months or longer DAPT group. Randomization was stratified by centers, diabetes, STEMI, and type of P2Y12 inhibitors. The primary endpoint was MACCE, which was defined as a composite of all-cause mortality, MI, or stroke at 18 months. The median age was 62, and 3/4 of all patients were male. Patients, more than 1/3 of patients presented with STEMI. Clinical characteristics, lesion, and procedural characteristics were well balanced between the two groups. The median duration of DAPT was 184 days in 6-month DAPT group and 431 days, about 18 months in the 12 months or longer DAPT group. A substantial portion of patients in the 6-month DAPT group received P2Y12 inhibitor after 6 months. The rate of MACCE primary endpoint was 4.7% in the 6-month DAPT group and 4.2% in 12 months or longer DAPT group. There was no significant difference between the two groups, and the non-inferiority of 6-month DAPT was met. However, in landmark analysis at 6 months, showed that MACCE tended to occur more frequently in the 6-month DAPT group than 12-month DAPT group. Myocardial infarction significantly increased in 6-month DAPT group compared with the 12 months or longer DAPT group, especially between 6 and 18 months when actual treatment differed between the two groups. Notably, non-target vessel MI occurred 4 times more frequently in the 6-month DAPT group compared with the 12 months or longer DAPT group. However, the rate of death, stent thrombosis, were not significantly different between the two groups. Bleeding, BARC type 2 to 5, tended to occur less frequently in 6-month DAPT group compared with 12 months or longer DAPT group. However, the major bleeding was not significantly different between the two groups. In meta-analysis, including 3 trials, SMART-8, ADAPT-STEMI, and REDUCE trial, showed consistent results. There was a strong trend for increased risk of myocardial infarction in the short DAPT compared with the long DAPT. There are several study limitations in our SMART-8 trial. First, randomization was performed at the index procedure rather than 6 months. It was an open-label trial, and a considerable proportion of patients in the 6-month DAPT group received a P2Y12 inhibitor after 6 months, which was a study protocol violation. Clopidogrel instead of Prasugrel or Ticagrelor was predominantly used as a P2Y12 inhibitor. Our findings apply only to ACS patients undergoing PCI using current generation DS, not those undergoing CABG or receiving medical treatment only. In conclusion, the increased risk of myocardial infarction with a 6-month DAPT prevents us from concluding that short-term DAPT is safe in ACS patients undergoing PCI with the current generation DS. Prolonged DAPT in ACS patients without excessive risk of bleeding should remain the standard of care. Thank you for your attention.
Thank you, doctor. Thank you so much.
So next, we will invite Dr. P.P. Mohanan for his presentation on complete revascularization in ST elevation MI. Dr. Mohanan, please.
Respected Chair and dear friends, earlier in the day we listened to Dr. Srinivas Kumar, who told us there were about 56,000 primary PCI done in the year 2016. And it would have been wonderful if we know how many of them underwent a complete revascularization. Well, this will be my agenda. The idea is, over the years, every guideline has suggested that in cases of STEMI, a culprit vessel revascularization is mandatory. The debate always is there whether you should be doing an ad hoc complete revascularization. Unfortunately, we have a predominant, at least 40 to 50% of the STEMI that we see across has multivessel disease. And this decision is very important. This particular subset of STEMI with multivessel disease has, in fact, the short-term and the long-term mortality is definitely higher than the other groups. If you look at the PCI strategies in STEMI patients, mostly, for example, the NCDR shows about 92% of the PCI strategy in STEMI is a culprit vessel only. Even though we have more and more data on multivessel PCI, ad hoc, which can be done, the multivessel PCI with primary PCI, and then the staged PCI, which you may do in the index hospitalization or later. Well, going through these, you would see that there are more disadvantages for a multivessel PCI in the setting of a primary PCI, mainly being you have a longer time, a higher contrast load, you have more radiation exposure, it's an intense thrombotic milieu. You could be doing more harm when you do a multivessel PCI. That was the thinking. And naturally, if you look at the older guidelines, it said that it will be harmful to do a non-infarct related PCI in the setting of a STEMI. And we have, again, a lot of meta-analysis. But over the years, the newer innovations in the interventional technology, newer DES, newer potent antithrombotic drugs paved the way to change this particular concept. And so much so, the ACCHA, when it wrote the 2015 focused update on STEMI, changed it from harmful to a class 2B indication for a complete revascularization STEMI. And the ESC 2017 guidelines gave it a class 2A category. Of course, I should admit that there is nothing from the appropriate use criteria pundits. Well, what changed this concept essentially was at least the 4 randomized control trials and a galore of a huge number of meta-analysis based on these trials. You could see that these are the 4 randomized trials which focused on doing a multivessel PCI, and you could see that out of the 4, 3 of them were done during the index hospitalization, majority of them. And 2 of these complete revascularization were also guided by FFR. Both the Dynami 3 primality and the Compare Acute were helped with FFR imaging. Well, PRAMI is something which every one of you know, and this was a trial which was stopped earlier because of the excellent results. And you could see here that the death from the primary endpoints of death from cardiac cause, non-fatal MI, stroke, refractory angina, revasc, everything was substantially reduced with a very impressive p-value. The second in the complete revascularization trials was the culprit trial, which again a larger number than a smaller number, only 296 patients. Here again, you could see that the results looks very impressive, very significant reduction in the primary endpoints. Look at the number one, the MACE reduction was really impressive. A sub-study of the culprits showed that, an MR study showed that, well, there may not be much advantage when you follow these patients in terms of a residual ischemia. The Dynamic 3 was the first complete revascularization trial in STEMI, which used a FFR help. Mind you, this was done the complete, after doing the culprit angioplasty, they did the complete revascularization on the second day. That was the difference. Now, this is not an ad hoc multivessel PCI. This was a staged PCI. And that also showed very, very impressive results. But again, I will draw your attention into that. Most of these impressive results is based on a significant reduction of repeat revascularization. And the last of the 4 trials, which stressed on the importance of multivessel primary PCI, was compare acute with a large number, which again gave us a very impressive results. Here again, they used the FFR help to decide on, for example, here, and 50% of the those cases were angiographically proven. They were about to do a PCI on the culprit vessel, was avoided by doing a FFR, while in the Dynami, 30% were avoided by doing an FFR. We have again 2 large registries which again showed the same thing. Now you could very well advocate the multivessel ad hoc primary PCI. We have again, as I said, a galore of meta-analysis came which suggested that it is possibly time to change to multivessel. You have a better results with a complete revascularization. You could see the forest plot curve, which again, most of the things you could see that favoring a complete revascularization than a culprit vessel revascularization. You have now paired meta-analysis, network meta-analysis, you name it. Any network, any meta-analysis, it is there. So does it all these randomized trial and meta-analysis ask you to suddenly change over to a multivessel ad hoc PCI? We have to also know that not everything may be in black and white. If you look at the cardiogenic shock situation, the PCI strategy in 2013 was, again, they suggested a complete revascularization in cardiogenic shock or any situation where there is a hemodynamic compromise. But look at the culprit shock trial. Little shocking, which showed that you only do a culprit lesion in cardiogenic shock. So, things could be a little funny. It went on to say, culprit shock went on to say that this is the largest European multicenter trial in cardiogenic shock, and you better do only a culprit vessel PCI. But maybe more balancing the view will be, now these are the another meta-analysis which has come at least 1 year ago, which tell us that maybe complete revascularization, absolutely one should do it rather than a culprit vessel, but not necessarily a multi-vessel primary PCI. Better thing possible to do is do a staged PCI, and best time where the things settles down is maybe about 24 to 48 hours. These are the 2 meta-analyses which sort of told us that this may be a balanced view of doing a staged PCI. So gentlemen, ladies and gentlemen, the consensus is mounting that support a multi-vessel PCI in STEMI compared to the culprit vessel PCI alone. And we have a large number of patients, STEMI patients with multi-vessel disease. But mind you, many of this data have shown is basically showing a reduction in the primary endpoints based on a reduction in the repeat revascularization. One has to individualize your decision on complete revascularization, whether to do. We agreed on complete revascularization, no doubt. Whether we have to do at the time of the primary PCI or if you have to do a staged PCI will be something which you have to individualize. And imaging, definitely, FFR guided strategy looks better of course there are, I'm not negating the fact that FFR is not it's not, when many people are not enthused about using FFR in the staging of acute STEMI. What will I do? I will not say, it's a oxymoron to say a conservative interventionist, but then this will be my idea. And if I will do a culpritplasty, and if the non-culprit vessel is an LAD, and I have a proximal LAD lesion with significant narrowing, thrombus containing, I will do a multi-vessel primary PCI and not wait for a stage PCI. Thank you very much for your kind attention.
Thank you, Dr. Mohanan, for that excellent presentation and summarization of the, I think, the most difficult subject nowadays, that to do it right now or to do it within 2 days or wait. So I think your opinion should be the ideal, that we should stage it if possible. Otherwise, in emergency, you can do it in the same procedure. I think, is there any question for the Dr. Mohanan? Chairpersons, please, if you want.
Thank you.
Thank you.
Thank you, Dr. Mohanan.